let me just throw the traditional hand grenade once in the middle of this table, and then we will move on. But every time the cost of pharmaceuticals comes up, the dreaded generic word comes up in the discussion. So I want to ask, I think it's a fairly subtle question, is there validated data to prove, now the word is prove here, that replacing branded drugs with generic equivalents could both save money and maintain efficacy? Is there proof? Everyone seems to feel it in their gut, but where's the data? Is there data?
Oh, sure.
Oh, good.
Of course.
Thank you.
So, I mean, I'll give you a very concrete example. So there's a study that is frequently cited comparing carboplatin paclitaxel with carboplatin pemetrexed in advanced lung cancer, and they were totally equivalent. Totally equivalent. Now, there's a whole story about the politics of how that got reported and how people have poo-pooed the results, but it was a randomized clinical trial after all. Nonetheless, carboplatin pemetrexed remains a very commonly administered regimen in non-small cell lung cancer, adenocarcinoma specifically. So the question is not whether there's validated data. I think, you know, in oncology, there's a lot of A compared to B, B compared to C, therefore A equals C kind of stuff going on. That's been that way in oncology forever. Up to this point, we've been pretty cool about it, but when money got into the discussion, all of a sudden we're not so cool about it anymore. But the fact of the matter is, there's a tremendous amount of equivalence, but variability in cost.
Okay, now we're talking about pathways here. So what I guess we're trying to roll this into is, should all pathways go with generics, or do you need to go with branded drugs?
So, I have a ton of experience in the pathway space. Some of them do and some of them don't.
Well, I mean, Irving pointed out earlier, you're going with efficacy first, you're going with toxicity minimization second, and safety along with that. And then lastly, you're looking at economics.
Mm-hmm. But there's no HER2 positive pathway in breast cancer that does not include Herceptin.
Yeah.
It does not exist, right? I think the question is, if you have a patient who does not have ALK or EGFR in non-small cell lung cancer, first line, non-squamous histology, what's the optimal therapy for that patient? And the answer is, nobody knows what the optimal therapy is, but there's been tons written about the variability and cost associated with those therapeutic choices.
Now, you have all been talking about flexibility. Whether or not you've got a pathway, you modify it based on an individual's particular needs. Mm-hmm. The question that comes up by providers, and I hear this, is there is a pathway, my insurance provider requires me to follow this pathway. If I deviate from the protocol, am I going to get paid? What's the answer to that?
No, I don't think that's true. I think that...
Well, they wonder about it.
We're pretty upfront in telling people that pathways are a great way to reduce variance and thus improve quality because it makes people think about efficacy and toxicity. But patients with individual characteristics that would make them need drugs outside of a pathway set of regimens can get other regimens because we don't mandate 100% adherence. We have a threshold, and beyond that threshold, all of the pathway companies, and John said, you know, you can go out and buy them, have drop-down menus that say, if you don't want to be in the pathway, here's a list of drop-down reasons why, or you can free text it. And that's acceptable.
And I think that's an important distinction. When you say don't get paid, my mind goes towards, you know, there's a floor, if you will, of compendia-based, acceptable for payment, and that's usually baked into policy, and the government has its mandates for adherence to those recognized guidelines. But I think pathways is a subset of that where we've said, you know, this is the filter that we use to embed some comparative effectiveness technologies, et cetera.
So the NCCN has 16 first-line therapies for metastatic colorectal cancer. We'll pay for any of those. But what we expect providers to do within the different clinical subtypes is to follow a pathway 80% of the time. They'll get paid for any of those 16. They'll get an incentive payment if they follow their preferred regimens 80% of the time. If they use something that's not in the NCCN guidelines, if we detect it in advance, they won't get paid.
All right. I mean, I can understand you're not going to pay for peach pits.
Yeah.
Let's not even go there. But what about your voice?